Desperate times call for desperate measures. This is especially true for many of us in healthcare, as we find ourselves adapting to new roles and new units, innovating to tackle a new disease while adjusting to a new surreal reality. Hence, in an effort to re-establish some degree of normalcy, we decided to resume the release of our episodes on the Neurocritical Care Society podcast. As I say, the show must go on, and at least now you can listen to something that is non-COVID related for the next 20 minutes. I hope you enjoy this episode.
Hey NCS podcast listeners, this is your host Fawaz Mufti from Westchester Medical Center. With the rapid evolution of neurocritical care, better comprehension of acute brain injury, as well as the relatively rapid influx of new medications, today more than ever, neurointensivists find themselves engaging and partnering with critical care pharmacists. From sedatives, hyperosmolar agents, vasopressors, or more specifically anti-epileptic agents, neurostimulants, or reversal agents, the pharmacotherapy of acute cerebral injury is undoubtedly complex and multifaceted. Hence, the NCS podcast decided to partner with the highly successful Pharmacotherapy of Neurocritical Care series, the PONS, in a limited release to cover pertinent pharmacological topics presented by experts in the field of neurocritical care. Over the course of the coming months, you will hear a number of selected PONS talks, but please do let us know if there are particular topics you would like to be additionally covered. Without further ado, here is the PONS.
Hello everyone, and welcome to the Neurocritical Care Society podcast. I am Jeffrey McSavage, co-chair of the Pharmacotherapy of Neurocritical Care series, or PONS subcommittee. For this podcast, we will be discussing the pharmacological care of patients that have been declared brain dead, but are still being medically managed in preparation of organ donation. It is a pleasure today to have Dr. Russell Dixon, who is a clinical pharmacist at Ascension St. John's Medical Center in Tulsa, Oklahoma, and also adjunct faculty at Oklahoma University and Southwestern Oklahoma State University. Dr. Dixon, welcome to the show. Before we get into the topic, can you tell us a little bit about your practice?
Well, it's a pleasure to be here today. Thank you, Neurocritical Care Society and Jeff, for the assistance in putting together this podcast. I appreciate your patience as we work through some of the challenges that we have here upon us recently. I have worked in the intensive care unit for over 10 years, commonly manage neurologic trauma and surgical critical care patients, so I often wear many hats. I'm a sub-investigator for several FDA-regulated trials. I've had the unique opportunity to be involved in facilitating the evolution of our potential organ donor management program here at Ascension St. John. Improved management of the potential organ donor was identified as an opportunity for improvement during one of our American College of Surgeons site evaluation. And so we sought out on a journey to help improve that process so that we could offer organs to those in need. This was the beginning of our management program. We began to develop institutional guidelines involving multiple disciplines throughout the hospital. We worked closely with our organ procurement organization. Soon we were up and running with an in-house organ procurement organization coordinator. I continue to be an active member of our organ and tissue donation committee and work closely with healthcare providers to ensure we stay up to date with our processes. I'm also currently working on a book chapter with other authors so that we can continue to increase the awareness of this wonderful opportunity.
Dr. Dixon, thank you so much for sharing that about your practice. I know for most of us working in the neurocritical care units, our work generally stops once a patient has been declared brain dead and the decision has been made to proceed with organ donation for the patient. And I really can't understate what a beautiful and ultimately life-giving gift that the patients and their families give in one of the most tragic and really difficult times of their lives. But the story really doesn't end there, and many of these patients continue to be medically managed before making the great gift of organ donation. I know as a pharmacist in the neurocritical care unit, our nursing staff continues to care for these patients, and I sometimes get asked drug information questions or other questions about the care for this patient population. So we really appreciate you coming on the show today to shed some light on this topic and help us better understand what really is next medically, and particularly the pharmacotherapy for these patients after the brain death determination in preparation ultimately for organ donation. My first question today is really, what are some of the primary factors to consider when hospitals or units are developing a successful organ donor management service?
I think it's important to initially, consider some of the potential barriers so that we can work through those barriers. One of the big challenges is that there really isn't high-level evidence, randomized controlled trials in this population. It's a difficult population to study, so finding the bits and pieces, the pearls of wisdom within that data can be very challenging. There's also, I work primarily very closely with trauma patients, so there's multiple different types of injuries to the CNS, which pose different challenges, whether it's blunt traumatic injury or penetrating injury to the cranial vault. Sometimes institutions have a lack of a systematic care plan, so they don't really have a plan on how to manage these, or there may be differences in opinions or ethical dilemmas that make it challenging to manage these patients safely and efficiently.
Very, very interesting. And I know from my personal experience, at least clinically, many of these patients are not very hemodynamically stable. What are some of the keys to the initial resuscitation of these potential organ donor patients?
Well, as we all know, there's always going to be a fluid debate. So what fluids do we use? And I'm going to kind of muddy the water just a little bit, because sometimes, during initial patient management, when I'm involved in the process, we may be faced with penetrating injury to the cranial vault that may transcend both hemispheres of the brain. And, that patient is already hemodynamically unstable due to brain injury. They haven't progressed to brain death yet, but we get involved and we choose fluids. Initially we're resuscitating to perfuse the brain and minimize secondary injuries. And so we choose fluids to help, in this case, maintain higher sodium levels. So usually normal saline is a good option as initial resuscitation fluid, in combination, if they have other injuries, hypovolemic shock due to blood loss, or things like that. So I think, assessing where you're at in the patient care continuum. So whether you're in the ED, what kind of injuries you have. So understanding, what part of the brain is injured, as you have that information in real time, assessing CT scans to determine which part of the brain could be injured. It's more difficult, with anoxic brain injury, patients that are found down. Those can be, very challenging. Do we have, primary injury that's causing a problem, or is this anoxic injury that we can't really identify early on a CT scan? So those are some of the things, kind of understanding what could be potential complications just due to the injuries themselves. Some patients you're gonna be involved with cerebrovascular injuries, so ischemic strokes early on, other types like that. I think it's important as a pharmacist in particular to understand what are the contents of each of those fluids, so that we can help providers, make real-time decisions on which fluids to use in that continuum of care. Also, looking at endpoints of resuscitation. So how do our goals change through that continuum? A lot of places are going to have almost institutional specific endpoints, at least initially. And then as you approach brain death, or you pass that brain death phase, then, some institutions may not have goals after that. So I think, ensuring that as you move through that continuum of care, you have a plan in place, who to contact to get the information you need and make those transitions as your patient progresses.
Thank you. And along those lines, our listeners really love clinical pearls, and I think you handed some out there. What are some other clinical pearls, specifically when selecting vasopressor agents for persistent hypoperfusion in these patients when they're refractory to fluid therapy?
Yes, I think there's a couple of things. Certainly, we're all very, most of the critical care pharmacists and providers are very familiar with, management of sepsis patient. We have very defined goals and steps along that line. But with these patients, there may be some unique things that we don't necessarily see every day, especially for those that are not involved with, traumatic brain injury and those types of patients on a day-to-day basis. So things like, again, kind of reflecting back on what part of the brain is injured. We may have things that come up early, like situations like diabetes insipidus. So that could be with or without hypotension. If you do identify diabetes insipidus with hypotension, probably one of your preferred vasopressors early on would be vasopressin itself. You want to replace that for the vasoconstriction component, as well as the decreased fluid output in the kidneys. If you don't have hypotension associated with that, then something like desmopressin may, help with the decreased fluid, so you don't have to deal with hypovolemic shock later on. Another scenario, again, this is more along the lines of after you have the confirmation of brain death. Some of the patients may have a decreased cardiac output. So things like something like dopamine may be a preferred agent in the beginning because it has more support for cardiac output. It may also decrease the effects of the cytokine cascade, which we see in traumatically injured patients because the inflammatory cascade is very profound. It may reduce the effects of reperfusion injury, and it may also decrease dialysis requirement after transplant for transplanted kidneys.
Oh, that's really interesting, and I never really thought of, taking care of that brain dead patient and then putting those organs, the outcome of that afterwards into the recipient, and that's really important to know that drug therapy decisions do have to kind of consider that. Also, critically ill patients in general have a whole host of potential complications that we manage daily, and I'm sure this patient population is no different. Besides some of the hypoperfusion that you mentioned, can you describe in more detail some of the other potential complications that may occur during the management of these patients?
Yes, as we know, as patients progress towards brain death, the brain, coordinates a physiologic response to help maintain perfusion. And those patients can go through very profound and high levels of catecholamines, called a catecholamine storm, which may lead to, as you progress towards brain death and you achieve that diagnosis of brain death, the cardiac tissue may become exhausted, similar to like a Takotsubo type cardiomyopathy, where the cardiac tissue is, similar to any other muscle. It can be exhausted, and very high levels of catecholamines can do that. So these patients may progress and be very tachycardic, sometimes heart rates up into the 140s and 150s, systolic blood pressure, 180 to 200 millimeters of mercury sometimes. And then all of a sudden they move to the next phase, and the nurse is looking at you. Initially they're asking questions about what do I do with this blood pressure? How do I, take care of this? And then, 30 minutes later, they're asking you, well, how do I resuscitate this patient? Now my blood pressure is below perfusion levels, and now I'm bradycardic. And so as you progress through that phase and that cardiac tissue becomes exhausted, there's something you can do to help with that once that happens. And we call that hormone replacement therapy. So we can use thyroid hormone replacement. You can use either T3 or T4 in combination with an insulin plus dextrose, because as we give insulin, of course, we don't want to become hypoglycemic, in combination with methylprednisolone. And this is kind of given as a cocktail, usually within 30 minutes once you progress through that phase. And this will help because, you can imagine, now you're bradycardic, now you're hypotensive, we're going up on very high doses of vasopressors, whether it be norepinephrine or dopamine, and sometimes you don't get there. And so you're just clamping down on blood vessels, and your cardiac tissue needs kind of a kickstart, the way I like to put it. And so this hormone replacement therapy can do that. And it can I've seen patients on very high doses of vasopressors, And in an hour or two after we do this, they're completely off of the vasopressors and they're hemodynamically stable. So it's a very unique scenario that can happen as the patient progresses towards brain death and completion of brain death. Also, you can see, kind of moving away from that topic, you can see a very profound activation of the inflammatory cascade. So this may actually cause damage to the lungs. The capillaries may become leaky, so the lungs become retain more fluid and become inefficient in exchanging gases. And, this inflammatory cascade can lead to profound systemic vasodilation. So you can add on methylprednisolone or other steroids potentially to help combat those effects in those brain dead organ donor patients, potential organ donor patients, to help combat those effects and help with lung transplant success, as well as maintaining blood pressure and those parameters. You can also get hypothalamic damage, which causes a dysregulation in the ability of the patient to regulate their temperature. And so you may need to use warming or cooling blankets, or sometimes you can use certain intravenous catheters that have cooling and warming capabilities to help thermoregulate those patients, because we know, temperatures too much one way or the other can cause significant other complications. So we want to try to avoid that.
Thank you so much for that review. And I think that really opened my eyes a little bit to how some of these different common therapeutic drugs are used in a very different way in this population that we may not usually be accustomed to in the critical care environment. So I just want to switch gears just a little bit for a question, and I was thinking about this. And while this overall brain death process generally, marks the end of one person's life, and there's obviously very emotional. How has your involvement in this process been rewarding for you as a clinician? And if so, if it has been rewarding, how and why?
It's been very rewarding. When you graduate pharmacy school, at least for me, the University of Missouri in Kansas City, they didn't talk anything about this type of a topic, nor being involved, in the management of trauma patients. There was very little information on that. So just being, involved in that process and developing this topic has been, very rewarding. I think the most rewarding thing, honestly, is just the transcending of the multiple disciplines that I've had to work with, from the first responders on the scene to emergency department staff, moving up to the ICU, including OR staff, anesthesia, surgeons, even administration, being involved in evolving this process and supporting this process. We have regulatory agencies supporting maintaining or managing these patients to explore the opportunity for donation. Doesn't mean that every one of these are going to be an organ donor, but it allows, resuscitating, helping support these patients in all phases of their care, can allow for the opportunity, honestly, for the family to see their loved one in a stable state, as well as to explore the opportunity for donation. I know, there's lots of ethical challenges that can be involved with this, and certainly can be very mind-boggling at times. But I think, understanding the process and being familiar with it, and working with multiple different providers has been very rewarding. The other aspect, to provide, to communicate with the families of these organ donors and to work with them, whether their loved one progresses to be an organ donor or not, has been very rewarding, and some of them, appreciate the added information, about organ donation, and that's been very rewarding as well.
Well, thank you for that, especially highlighting the interprofessional piece, how it really takes a team. And I think that really speaks well to the Neurocritical Care Society and those things, and how we really try to put in that team approach there. And I like that you really highlight those things for that. Dr. Dixon, thank you so much for coming on the show and sharing your expertise and experiences with this really unique patient population.
It's been a pleasure.
And it just, it really is very beautiful that at the end of life, there is hope for a renewed opportunity for someone else who is very ill to have a chance to live a better life from really this selfless gift that these patients and family members make. If you like this podcast and are interested in more details on this topic, please check out our PONS program on the pharmacological management of the brain dead organ donor, created by our colleague, Dr. Emily Doerr. It can be found on the Neurocritical Care website under the PONS section for continuing education. All PONS programs are eligible for CME for purchase and free to society members for educational purposes. Thanks for listening.
While there exists a legal provision for brain death, institutional protocols for diagnosis are not universal and are often absent, as no specific criteria for diagnosis is mandated. Available in both English and Spanish, the Brain Death Determination course, presented by the Neurocritical Care Society and endorsed by the American Academy of Neurology, aims to standardize the process of brain death diagnosis. This certification course, accredited for 2 hours of continuing education, highlights the necessary steps that must be taken, reviews the various exam methods, discusses proper documentation, outlines appropriate communication, and describes common pitfalls and barriers that may arise during the exam process in order to help clinicians, allowed by their local laws, to perform brain death determination. Visit www.neurocriticalcare.org/braindeath to learn more about the certification and use promo code PODCAST for an extra 10% off the purchase of this course.
The NCS podcast series is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and advocacy in neurocritical care. Our production staff includes Fawaz Al-Mufti, Ramani Baloo, Mike Brogan, Josh Levine, Benjamin Miller, Sterain Shepard, Jim Siegler, Sarah Sternnezer, and Chris Zamet. Our senior producer is Bonnie Rousseau. Our administrative staff includes Bonnie Rousseau and Angel Gindel. Music is created by Mohan Kadapali from the Division of Neurocritical Care at the University of Miami. The NCS podcast series is available on NCS On Demand and wherever you may listen to your podcast. For more information, please follow us on Twitter @Neurocritical or on Facebook. I'm Fawaz Al-Mufti, and thanks for listening.